Welcome back to episode 10 of the Best of Both Worlds podcast, Singapore's very own health and performance podcast with me, Matt Winter, Doctor of Physical Therapy with training in functional medicine, and Paul McCauley, senior podiatrist, otherwise known on TikTok as the legendary Paul the Podiatrist. Welcome back.
Cheers. Yeah, very well, very well. Good to be here. And today we're very lucky. We've got Neil Forrest back with us again, our favourite GP in Singapore. Could be our own doctor on the podcast,
like personal physician.
Yeah, exactly,
like that.
So, how are you doing out of 10 today, Matt?
Me, I'm struggling generally with technology. We've been rushing around all morning trying to get a new light for the podcast, which I achieved. So I'm very happy with that.
Beautiful.
I'm also like a few $100s poorer.
So it's worth it for the views.
Oh, 100%. So I'm going to go 6.5 to 7.
Nice, mate.
Yeah.
Well, I mean,
I don't know.
You always forget. Is anyone?
No, I know. No, it's all about me. How are you, mate?
Yeah, mate, I'm about 3 out of 10 this week. It's been a tough one. I went to Hong Kong last weekend and had a good time, but too good a time, and then struggled this week.
No, you looked absolutely hanging when you came back. Yeah. I like your beard.
Thank you.
Strong, very strong, Wolverine-esque.
Mature.
No. Yeah. What about this guy?
Yeah. How are you doing, Neil? Out of 10?
I'm 10 out of 10 today. Absolutely fine. Good night's sleep. Birthday tomorrow.
Oh, exciting.
So yeah, I'm all good.
Is that
Thanks for having me.
25?
Yeah, 26 actually.
Suck up. Right. Shall we get down to this?
Yeah.
So we're talking about health screenings today. We both just done ours. It was horrible to get those results. We really want to know who should be doing them and why.
Just before we get started on today's podcast, I just want you to hit the subscribe if you can, drop us a like, and even drop us a comment on anything you think we could improve or any episodes that you want to see from us. So today we're going to be talking about health screenings. And basically, imagine, Neil, I've just moved to Singapore. Like, should I do a health screening? I've got this corporate package. It says I've got one included. Like, should I do it? Is it worth it?
So I think, of course, the answer to that is going to be, it depends. Otherwise, we wouldn't have much of a podcast from here if it was a straight yes or no. So I think the answer for most people is going to be yes to some degree. But I think what we need to get into is who should be doing what and when, depending on which stage in their life.
Yeah,
exactly. I mean, from my opinion, I've seen a lot of people who seem to indulge in these health screenings almost like a lucky dip. As we said off air, that people often get a load of money that they can use for health screenings, and then they close their eyes and point, and they really want to make use of that cash. Do you think then that health screenings are out of control in Singapore and much of the Western world?
I think they can be. I mean, I think we're lucky in Singapore in the sense that the medical testing and the screening itself is fairly well regulated. So I don't think there's a high incidence here of people doing really sort of off-piste, crazy testing that shouldn't be done at all. I think the challenge comes because there's really good accessibility to healthcare here. So there's a really wide range of tests that people can choose from. And they're often kind of left on their own to say, well, you pick, you decide. And we're not always expert enough to make those decisions for ourselves. And so I think that's where the challenge comes.
So you don't think there are any like lab tests that are like done and that are just really a waste of time for people?
Yes, I think there are plenty of those. And I think that the value of a lab test can vary a lot. But I think more of an issue that I see here is just the wrong tests for the wrong person. It's not that the lab test was the problem. It might have been really appropriate for someone else in a different situation to do. But they're often sort of done at inappropriate times.
And is that because they've been sold that sort of package deal?
Yeah. So I think it's human psychology, right, to think more testing must be better. If I can test for something, then it has to be a good idea. So I think from a lab test perspective, tumor markers are a great example of that. So I see a lot of people coming to see me for second opinions with tumor marker results that they've had as part of a panel. They've gone for a screening, like you say, new to Singapore, and they've chosen a package. They haven't really chosen those tests specifically. They've just been part of the deal that they got.
Yep.
Those tests were never designed to screen for cancers. They're used in people who already have cancer, and we use them to see if their treatment is working. if that makes sense. So you've got pancreatic cancer, we have a tumor marker for that, and we see if it's going up or down as we treat your cancer. But to take someone who feels completely fine and run that test on them is not an accurate way to screen for that cancer. And of course, when the test comes back abnormal, then we have to dig them out of that hole and work out what to do next.
So there's obviously psychological risks there. So if we talk about, well, someone might say, but what's the harm in screening? What's the harm in getting these results and knowing a little bit more? What would your answer to that be?
So I think we talk about costs of a test. And when I say that, I don't just mean the financial cost, but of course that's a big factor. Some of these tests can be incredibly expensive. And so if it's not adding any value, then you've wasted a lot of money. But there's also the opportunity cost and the psychological cost of the test. So even if the test is non-invasive, it might cause you a lot of worry or anxiety. It might lead on to other tests that are potentially harmful and invasive and that could cause you harm. Or it may just have been, the opportunity cost. You would have been better off spending your time and your money doing something else that would have been really good for your health.
Yeah.
Than worrying about these tests.
Yeah, for sure.
Yeah, so I think it's really good to establish what's not good. And it probably comes down to that patient selection. So let's break down the demographics a little bit. Let's start with people under 40. And I think we can cover in this group, men and women together. What would you recommend off the bat for someone under 40 going for a health screening?
Okay, so yeah, I think it's a good idea to do men and women together in this one because there'll be a lot of overlap, although there are some subtle differences that I'll talk about. The first thing I should say is that, in your 20s, this should be when you're at the peak of your health and functioning. Some men their bones don't stop growing until they're in their early 20s. The brain doesn't fully mature until you're about 25, 26. So you really should be optimal at this point anyway. So it would be legitimate, I think, to say to a lot of people in their 20s, you don't have to do anything at all if you don't want to. Absolutely fine to go through that period of time without any medical screening. And remember, when we talk about medical screening, we're talking about people who feel completely well, screening for something that they don't know they have or a risk. It's very different if you've got symptoms. If you've felt a lump somewhere or you feel awful or you're tired or whatever, then that's not screening anymore. We're investigating those symptoms. So here I'm talking about people who feel great. There are, of course, some things that they could be doing themselves. So men in this age bracket are most at risk of testicular cancer. This is where the peak happens. And so self-examination of the testes and reporting any changes to their doctor would be considered a form of screening, but it's self-screening. But do we drag 20-something-year-olds into the doctor once a year to examine them? Not something that I would recommend. Skin as well is also something that people would self-examine. You notice a mole that's new or changing, you might go and get checked out. So people can do self-screening. But in the main, if they didn't want to do anything at all, that would be absolutely fine. I think the exception to that in terms of an actual guideline recommended screening program would be cervical cancer screening for women, which does start at a young age. In the UK, where we're all from, it starts at 25. It did, when I left for Singapore, start a little bit younger in Wales. I don't know whether they've equalized that, but some countries 20, some countries are 25. So that is something that I would highly recommend for women. But it's, with the newer testing, it's only once every 5 years. It's not a particularly regular thing that they have to do. I often get people in their 20s and 30s coming to see me saying they do want a general check. They want to run some blood work and that kind of thing. Now, whilst that might not be necessarily recommended, I'm absolutely fine with doing that. I think it's okay for people to check their basic parameters on a blood test at that age. I don't think it's particularly harmful, and it can give some useful information about early signs of disease or preventative things that we could start to do.
Yeah, things like liver function. Obviously, if you've been to university in the UK, you want to check that in your early 20s maybe, and maybe blood sugar levels.
Yeah.
If your diet's got a bit out of control or something like that.
Exactly. So I think the great thing about younger people is they have a lot more runway to do something about it themselves. So if someone comes to see me and their cholesterol's a little bit high, or it'd be unusual to see high blood sugar, but maybe some early warning signs for diabetes or metabolic dysfunction, then that would be a great opportunity to put lifestyle changes in place so that we could avoid those things developing in the future.
Yeah, it's about choosing the right test. I mean, you said there that they might not show high blood sugar levels, but their fasting insulin levels might be high. But that doesn't come on a normal health screen. So again, necessarily, right?
It does when you see me, but yes, you're right. No, that's why there's plenty of places. There's plenty of places where that wouldn't be relevant. And again, why we should always be aiming to sort of personalize this to the best. For someone who's young, slim, excellent lifestyle, no family history of metabolic dysfunction, yes, checking and fasting insulin may be overkill for them, but I think, a lot of the patients that come to see us at Osler are thinking about their health early, wanting to be very proactive. And so whilst I'm fine with a 25-year-old not doing anything, someone comes to see me and they want to have these conversations and they want to get the ball rolling early, I'm not going to deny them that opportunity.
We've got a podcast coming out on cardiovascular screening than we did with you. I guess one thing they could test early would be that LPA marker. Is that something that you then, now the guidelines apparently are moving toward everyone to get that checked once? That's what you said around.
Yes.
So is that something that people could check in their 20s?
Yeah, absolutely. So, I mean, from a cardiovascular perspective, having your blood pressure checked young, we do occasionally see young people with undiagnosed hypertension. Your standard lipid panel, so would reveal something like familial hypercholesterolemia, which is an inherited very high cholesterol. You might not know you've got a family history of that. And as you say, lipoprotein A, which you only need to check once, but if that was elevated, it reaches its steady state at around age 5. So you could check it any time after that. So if someone was being really proactive, absolutely. What I probably wouldn't do to someone at that age would be put them on a treadmill, send them for a heart scan. Some of the cardiovascular screening that would be completely appropriate in an older person.
And so if we then move on to over 40s, I think we're going to split this into male and female. So you can go through the, what's the word? Nuances of the two. Fancy word for me.
So I guess let's talk first about the similarities between the two, and then we'll separate out the male and female. I think one of the things that shifts between these people in their 20s and 30s, and then maybe let's say 40 plus, is I would be far more confident to say it's a good idea to make this an annual thing now. So whilst I would encourage people to start thinking about their health and maybe running some basic tests even younger, if they were doing it every couple of years, 3 years, if everything was normal, that would probably be okay. I think once we get into our 40s, it becomes reasonable at that point to say, I'm going to do this on an annual basis.
Yeah.
So even those very basic tests that we talked about, blood count, liver and kidney function, cholesterol, diabetes, those things you should start doing annually. Then there's the other sort of screening tests that come along that are more sort of like big ticket items beyond just blood test. So for women, breast screening's a very obvious one. So we've said cervical cancer screening starts from your 20s. Breast screening in Singapore is recommended from 40 onwards.
Just a stat from the New England Journal of Medicine, 31% of breast cancers diagnosed on mammography were found to be what they said is overdiagnosed. So these people would never exhibit symptoms or die from the breast cancer. Obviously, that early mammography finding would lead to more invasive investigations and potentially treatment as well. So how do you advise someone that's come in, they're 40 years old, on whether they should be going for, say, breast ultrasound, mammography, or nothing at all?
Right. So I think we can use breast screening as an example that's sort of applicable to a whole bunch of other types of screening tests as well, because it's a great one. And you've already highlighted some of the challenges with that. So when we think about a screening test for something that's looking for a sort of binary outcome. Have you got cancer? Have you not got cancer? This is different to, say, as Paul mentioned, liver function tests, which are sort of on a spectrum, always sort of moving around slightly. For cancer screening tests, there's only one outcome of interest that we're really interested in. There's a few prerequisites that you've got to have. So you've got to be able to have a test that works and is acceptable to the population. If the test's so awful that no one wants to do it, then there's no point. You need to be able to catch the disease at an early enough stage that you could do something about it. Otherwise, there's no difference between being screened and not screened. You may as well just wait until you get sick. And then you've got to factor in other things like cost and all the rest of it. So breast cancer screening, as the treatment for breast cancer has improved over the years, as you can imagine, the bar for screening being any good gets higher and higher, because as the treatment improves, so many women now survive that the women who were diagnosed through symptoms have been catching up with the early stage ones that are caught through screening. So we do still think breast screening is worth it, but like any test, you make the test more effective if your pre-test probability is higher. That means if the person's got more chance of having the thing you're looking for, you've got more chance of it being a better test. So there is no point screening women in their 20s for breast cancer for that reason. The pre-test probability is so low that all your positives are going to be problematic. You're going to massively overdiagnose and overtreat.
Is that a group that can be doing self-checks though?
Yeah, absolutely. So we would still encourage self-examination and reporting of symptoms. That would be breast lumps or skin changes or nipple changes, but not breast imaging. I suppose another group that you've got to think about in the under 40 category would be people who had a strong family history, first-degree relative with breast cancer, particularly at a young age, or people who know they have a genetic risk factor. So with now genetic screening is more common, more people know that they have a BRCA1, BRCA2 gene, and they might want to go into screening at a younger age, and that might be completely appropriate. So when I say 40 onwards, I'm talking about the general average risk population of women. But even in that group, there are problems. So about 1 in 8 women with a breast cancer will be missed by, I'm talking about mammography on its own here. So that's a problem. So those are false negatives. That's a problem with specificity of the test. And then what you mentioned is overdiagnosis. So overdiagnosis can mean two different things to different people. You could be talking about finding something that then doesn't turn out to be cancer. That's a big problem. So we see lots of women with lumps, indeterminate adenomas, this kind of thing, who then have further tests and they don't have cancer. The other thing that overdiagnosis can mean is finding a cancer that never would have led to anything, never would have spread, never would have killed the person, that kind of thing. Actually, that's relatively low for breast cancer screening. If you find a cancer, the chances are it does need to be treated. We think somewhere between 1 and 10% probably never would have caused a problem, but most of them would. I think a much bigger problem is finding this stuff that isn't cancer and then having the anxiety to deal with either what we will say is, okay, repeat the scan in a few months, so you've got a long time to worry about it, or go and have a biopsy, which is invasive and painful and leads to more worry. So there are things we can do to reduce the risk of those problems happening. So you mentioned ultrasound. So in certain women, adding ultrasound onto mammography gives you an additional imaging modality. So something might look a little bit suspicious on mammogram, but on the ultrasound, it's really obviously that it's completely benign. So by doing those two tests together, you actually give yourself a little bit more information. 3D mammography, more accurate than 2D mammography, but it's more expensive. And so selecting the right groups of people and then doing the right kinds of tests on them would lead me to recommend to my patients, hey, listen, you come to me as a woman, you're between 40 and 50. I would recommend that once a year you should do breast imaging if you can afford to do it and you have access to it.
Yep. And so to clarify, that's mammography and ultrasound for a woman.
Yeah. So some of the things that lead to risk of misdiagnosis or overdiagnosis are having denser breast tissue, which tends to be premenopausal women, being on some form of estrogen, which is often the pill, never having had a mammogram before, because remember, when they see something abnormal, they compare it to your previous ones, and if there's nothing to compare it to. So I tend to recommend mammogram and ultrasound in these younger women. Post-menopause, as the breast tissue changes, you can probably shift towards just doing mammography, which is quicker and cheaper.
So I know we sort of talked about this in the younger age group. So for someone, just to clarify, under 40 with no symptoms, no strong family history, they don't need to go through routine breast screening.
No, I wouldn't recommend it, no. And so if they are being offered a screening package where that was part of it, I would politely decline it. And that would be an example of a problem with overdiagnosis. Same thing is true in cervical cancer screening. So if you screen women younger, say at 20, you will avoid missing some of those very young onset cervical cancers, which are an absolute tragedy when they happen, but you'll also overdiagnose a whole bunch of abnormalities in these young women that then turn out to be nothing. So we're always, as doctors, I think, walking this sort of tightrope between risk and reward with screening tests. And I find this very interesting, as you can probably tell, but it can be very confusing and a bit of a minefield for the patients.
Quick question on cervical cancer screening. Does the patient need to be sexually active to do that screening? Does that come into the decision?
Yeah, it's a really good question, because I think that's often not mentioned, right? So essentially 100% of cervical cancers are caused by the HPV virus, which is a sexually transmitted infection. Doesn't have any symptoms, but that's how you catch it. So if you've never had sex, you don't have to do cervical cancer screening.
Yeah, perfect. And so for the men over 40s?
Yes. So we got sort of sidetracked into breast screening. Is there anything else? I guess the other thing I would say about women is often where testing and sort of some forms of screening comes in is pregnancy. So women have this thing that happens to a lot of them in between 20 and 40. So
It isn't it? Mysterious accidents.
where they'll have a bunch of blood tests and so they will have some medical contact. Whereas I think sometimes it's quite easy for a man to breeze through from his 20s to 50 and never really have an in-depth conversation with a doctor. You might go with a cough or a cold, but no one ever sits you down and says, well, tell me about your family history, or let's check your blood pressure or something like that. So women do have this. Obviously not all women get pregnant, but the majority do. And so they will have their sort of blood pressure screen. They'll have their kidney function screen. So that can be revealing at that time. But as you move into the sort of over 40 age group, so for both men and women, the gold standard recommendation that I would give to my patients for all of them to do if they could would be to start colon cancer screening from 45 years old onwards. And the gold standard method of screening would be to have a colonoscopy every 5 years.
Lovely.
Yeah, something for you both to look forward to.
No, I've had 2 already. They're very, very enjoyable. Actually, I would say it's the worst thing about those screenings is the prep, isn't it?
What everyone says, yeah.
You have to take this laxative essentially, which I tend
Clean the tubes.
clean the tubes. I tell you what though, I think it cured me. I had before I had my screening, which I mean, obviously there's a reason, right? Sort of IBS type symptoms,
Right.
And I took this laxative. After that, felt great. Do you know what? It cured it.
Interesting.
So I think it just almost like reset my gut microbiome.
I mean, the claim is that the prep weirdly doesn't affect the microbiome adversely, because that would be a big worry for a lot of people. If you were going to sort of clean everything out, would you be cleaning the good stuff out as well? It doesn't seem to be the case, but yeah, I guess for a lot of people with IBS symptoms who are more constipation dominant, it might be quite helpful.
So I think also you're not allowed to eat certain foods over a few week periods. So that probably helped as well. But yeah, so no, it's all good though. It's not.
Yeah, so for someone like you who had a colonoscopy for some other reason, that might change the age at which you start colonoscopy. But as a general recommendation, now the reality is, I think of all the things we talk about, this is probably the one that the fewest people actually do. And that's because colonoscopies are procedure, so it's expensive, and a lot of insurance policies will not cover you to start screening from 45 years onwards, even though that's the US recommendation.
But let's be like really clear. This is the most common cancer when you combine men and women in Singapore. So if any country is going to push this, surely this should be the place.
Yeah, I mean, to come back to the UK, where we're all from, a public system like that really struggles to afford across the board colonoscopy screening. So they look for alternatives. So in a lot of countries like the UK, what will happen is people will be sent stool test kits to do either stool blood tests or fecal immunochemical testing, which is better than doing nothing. And that's something we offer as well. I'd still encourage people to do that if they didn't have access to colonoscopy. But the reason colonoscopy is so powerful is because it's not, when I talked about the characteristics of a good screening test and I said we need to be able to catch stuff early, colonoscopy is looking for polyps years before they become cancer and then removing them at source. And so it's a test and a treatment in one. Whereas with these stool testing kits, by the time something is showing up on there, we think you're probably further down the road of the disease than had we caught it when it was just a polyp.
Okay, good. So we've got, for women, we've got mammography plus ultrasound. For both sexes, we've got colonoscopy is a highly recommended, right?
Yeah.
Gold standard.
Yeah.
And then, so that's covered breast and sort of digestive tract. What else have we got?
So I guess when I sit down with a patient, we have a long conversation, right? We talk all about their lifestyle to begin with. I mean, that's always my focus, really. Then we move on to their own medical history, then their family history, and then I examine them. Then I get my iPad or my piece of paper out and we start to map out the testing we're going to do. And the way I often divide it up is because remember, this is preventative screening. If we find a condition that you happen to have that we didn't know about, then that's quite lucky. But really what the thrust of what we're trying to do is stop bad stuff happening in the future for you. So I listed out of the things that are most likely to kill you: cardiovascular disease, cancer, metabolic disease, and neurodegenerative stuff like dementia and Parkinson's and things. So we've talked a lot about cancer screening: colon, breast, cervical. I guess the other one for men would be prostate cancer screening, which we'll get into in a moment. But one that applies to both men and women is cardiovascular. It's the thing that we're all most likely to die from. And I would say that somewhere between 40 and 50 for most people is where I'm going to ratchet up the cardiovascular screening a little bit. So we will have already done blood tests and blood pressure and things like that in the past, but this may be the age where we start thinking about cardiac imaging or other modalities to further establish what your risk is.
Like checking my HIV, whether it's real or whether it's actually age revelation. Yeah.
Well, that's a great point, right? So we're talking a lot here about sort of biochemical testing and imaging and that kind of thing. What we haven't mentioned is all the digital data that people now arrive in my clinic with. They've got their Oura Ring, they've got their Whoop band, they might have a continuous glucose monitor. Yeah. I mean, I would say though, with those things, and they're super important, if you've noticed a problem on one of those things, we're veering off into investigations now, not so much screening, if you know what I'm saying. Yeah. So you're using those more as diagnostic tools than screening tools.
Yeah. Matt's markers are all over the place, so he needs to test everything. So with regards to like testing for over 40s, should they test any hormones at all?
So yeah, it's a good question. I mean, obviously this is through the 40s is the age for most women where perimenopause into menopause is going to happen. And we're not going to get into that because I know you've done podcasts on menopause already. I think it's important on that front to say that the menopause itself isn't something we generally screen for with tests. We would base that decision far more on symptoms and how someone's feeling than running blood tests. Now, if we're talking about something like HRT, we may want to run some hormone tests before, but I wouldn't automatically include them in a screening package. Related to that, I guess, is other medical conditions that can come along at that time related to hormones. So menopause is a point for women where estrogen is essentially withdrawn from the body and drops to very low levels. the knock-on effect of that in some women can be a reduction in bone mineral density. So that's often the sort of ballpark age where I would recommend a bone scan. A bone scan's a bit like an X-ray. It's inexpensive, low radiation, and it tells us what your bone density is and whether you've got osteoporosis or you're at risk for it. And there are things we can do to prevent that.
And when we say bone scan, we're talking about a DEXA scan.
Yes, exactly that.
Yeah.
The other one would be ovarian cancer. So we've talked about breast cancer screening and how we do that. Ovarian cancer is more problematic. So the screening tests we've got are not ideal. There's ultrasound scan of the ovaries, which is not very good at picking up small early cancers. And there is a blood test called CA125, which is one of these dreaded tumor markers that I mentioned, which it can be quite sort of sensitive, but there's a whole bunch of other reasons it can be elevated. It's not very specific. And so it's not something that we have a great test for. And so that's a really personalized conversation. I mean, I think if someone's got hereditary or genetic risk factors, they're almost duty bound to do some of those tests. For other women, it's a discussion and then an informed decision.
So just for the people listening, are there any risk factors they should be thinking about when they go to their doctor and think, I'd like to do an ovarian cancer screen?
Yeah, so it would mainly be around family history. So to some people, that's genetics. So they may actually know that again, we come back to BRCA1, BRCA2 family carriers. Or they may just know that there's a strong family history of breast or ovarian cancer in their family. The other ones would be, and I'm sorry, I don't know these off the top of my head, but certain populations. So I know in the UK, Ashkenazi and Sephardi Jewish populations have much higher rates. So they are almost sort of steered into early genetic screening and family-based screening at a younger age.
Same to you, Matt.
Yeah.
Nice, mate. Nice. Just if you didn't know.
Well, I'm less likely to have ovarian cancer.
I think so. So if we're still talking hormones, but we're talking about men, and we saw in the news recently that Chris Hoy has been diagnosed with prostate cancer. What would you recommend men going for this test?
Yeah, so this is one of the most problematic areas of testing that we're going to talk about, I think. I mean, we mentioned hormones in men. We've done a whole podcast on testosterone, so I'm not going to go into that now, but that is something that we may include in screening around this sort of age group, because it's often the age where it can start to decline. But from a prostate screening perspective, I've been getting asked this question lots in the past week. So for those that don't know, Chris Hoy was in the UK press at the weekend, sort of announcing that his prostate cancer is terminal at 48 years old. So incredibly shocking in someone who's been held up in our lives as someone who's the peak of physical performance and health. And so a lot of guys that I know have been saying, just get tested. It's the right thing to do. Come on, lads. We're in this age category now. And I've got sort of friends or guys I play football with or whatever who have been going and having testing done in their 30s and 40s. And I'm not sure that's a great idea, even though the news headlines are quite shocking. And again, it boils down to this pretest probability. So men under 50 are not impossible, but very, very unlikely to have prostate cancer. So that's one problem. Another problem is the test. So PSA testing, which is a blood test, is not the most accurate test in the world. I think it's safe to say. So when we talk about colonoscopy as a super gold standard screening test, it really is. Now, the problem is it's really expensive and it's really invasive. PSA is just a blood test and it's relatively cheap. So that's great, but it's just way less helpful as a test. So it's possible to have prostate cancer and not have an elevated PSA. And it's also possible to have an elevated PSA and to be completely fine. So both of those things, sensitivity and specificity, are an issue. So what do we do to improve that? We increase the pretest probability. So we target men in the right age group. Now, a lot of national guidelines, I mean, the US Cancer Association guidelines very famously say, we don't recommend PSA testing at all, but over 55, have an informed conversation with your doctor. And they sort of put it back on the doctor and the patient as an individual. I think there's been a subtle shift over time in that. I think what people saw when PSA testing first came in, a lot more men were diagnosed with prostate cancer. And that's a problem because many of them would have just been fine and would have lived a normal, healthy life with their prostate cancer. But prior to PSA testing, if you were diagnosed with prostate cancer, it generally spread around your body at the point at which you were diagnosed. So fatality rate was really high. Now, the fatality rate of prostate cancers, something like less than 10%, because most of the prostate cancers we pick up are really, really early, which I guess tells you that in practice, a lot of doctors ignored that advice to drop PSA screening. And when they had that individualized conversation with their patients, in my experience, most men over 50 are still doing the test. And I'm kind of with them. I know that it's problematic, but I think it's better than doing nothing in that age bracket.
Yeah.
If either of you guys came to see me and say, could you check my PSA? I'd tell you to have a really long, hard think about it. In fact, I think I may even just say, no, try and find another doctor.
Yeah.
So I don't think it would be a good idea unless you had some other great reason to test it.
Yeah. Yeah.
Does that make sense?
Yeah. I think that does clear that one up. Good. So I think we've covered the main things people should do and the main things people should consider not doing. For the biohackers that are listening, the sort of keen beans, they've got their Whoop bands on, they're doing their continuous glucose monitoring, and they want to sort of take that next step. Are there any sort of add-ons that you might say, hey, actually, do you know what? This one's quite a good one to do.
Yeah. So this is a really common conversation I have because again, there's a lot of the patients that see me and the team in Oslo are looking to go that extra mile and be very proactive in terms of optimizing their health. So we kind of shifted beyond screening for disease here a little bit and move more. I hate the term biohacking, but for want of a better phrase, whether it's longevity or biohacking or health optimization. So there are a bunch of other tests we can run that people are interested in. It's important to say that these are generally things that your insurance company is going to have no interest in covering. But we do like people to think about investing a little bit in their health. Now, for everyone, that's going to be different in terms of how much they're able to invest in their health. But in the same way that people spend money going on holidays or going to nice restaurants, it may be that you want to go that extra mile on some of your health markers. So, I mean, I think for younger guys like you, a great place to start would be something like a VO2 max. A really powerful predictor of how long you're going to live and how healthy you are, because you can't cheat the test. Not that expensive, and unless you fall off the treadmill or the bike, not particularly harmful to you.
Everything's possible, isn't it?
Unless Matt's just like, oh, my knee, my hands, my health, I don't know if I can do it.
No, better now. I told you about my 2.4K time.
So that, and another one that often goes alongside that in my experience is people wanting to do DEXA scans. Now, we spoke about DEXA scan for bone density. You can use the same machine to run a whole body composition.
Yeah,
so
we did.
So this is a sort of a more accurate version of your sort of in-body type scanning to really know what your body composition's like. So those are common ones. We have a lot of patients who are interested in their gut health and want to do microbiome testing. So that's something that we do a lot. I think incredibly important and powerful, still in its infancy as a scientific discipline, if you like. And I still think we're getting better and better at collecting data sets and actually giving people meaningful, actionable advice. I think even in the last few years, that's got better, but we've still got a long way to go on that one. A lot of people are interested in longevity and aging and geroscience. And so I see patients who have done genetic testing. That means genome sequencing, direct-to-consumer stuff like 23andMe or Circle. We run epigenetic tests for people who want to do them. So that's not looking at the genes that you can't change that code for stuff. It's the areas around those genes that modify the gene expression that can be changed through your environment and lifestyle. So that's something we're quite interested in. And listen, the list goes on. Full body MRI scans.
Oh, do you know what? Can we stick on that for 1 second?
Of course we can.
I think that's the bane of my life.
Yeah.
When I see those advertised, it brings me fear. And because even from a musculoskeletal point of view, we know the specificity or the clinical relevance of some of the MRI findings are horrendous, and actually add a lot more confusion, fear, and they change management often negatively. That's just when they have got pain in the area they're scanning.
Yeah, people obsess over them.
Yeah,
So I mean, I think it's so dangerous. This is a pet peeve of mine. I was going to bring this up.
it's a minefield, and yes, so this is very much outside of the sphere of conventional screening, as we've just said. Traditionally, it's been done in this part of the world by putting someone through an MRI scanner and having a human being, a radiologist, report the scan. And as you correctly mentioned, the problem with an MRI scan is it's better at looking at some parts of the body than others. And it's a very, very high resolution scan. So you see lots of what we call incidentalomas, lots of incidental findings that don't mean anything, but we can't quite tell what they are on MRI. So the same way, if you looked at my skin, you'd see blemishes everywhere, but that weren't really that important. The same is true on the inside of our body as well. What you have now increasingly in places like the US is AI powered analytics of full body MRI. So the most well-known company is called Preventative. And what they're claiming to offer is the fact that the AI is so much more intelligent than the human radiologist that we can filter out these incidentalomas. I think that's yet to be decided. And certainly, some of my colleagues in the US that I speak to on this have seemingly shifted towards different imaging modalities for different parts of the body. So in their patients who do want to do full body imaging, they might do a low-dose CT for the chest, for example, because the lungs and the heart are moving. MRI is a bit rubbish at that. They do an MRI for the brain. They do an ultrasound for the pelvis. Now, the downside of that is it's even more expensive than the full body MRI, but it's probably a more accurate way of looking at the body. I think for most young people, this is not something that I'm going to be going out there and recommending and shouting from the rooftops. But the reason I bring it up is it's something we see people doing more and more, and so we have to have the conversation. I would say the final one to mention of these sort of outside of the box tests, which is becoming incredibly popular now, is something called multi-cancer early detection screening. So this is the idea that you can take a blood sample from someone and screen it for cancer DNA and look for cancers at a very, very early stage before they would have been evidenced on a scan or as symptoms. The first or the most well-known company to do it in the US is called Grail. And understandably so, because this is kind of one of the holy grails of medicine, that if we could just take a blood sample and sort of make all these diagnostics from it, it would be incredible. And so we have those those are here and now. We have those cancers available in Singapore. I think my issues with them, one is they're still very, very expensive. So they're not accessible to a lot of people, thousands of dollars to run these tests. And you need to run them every year for them to be helpful. The other would be really counseling that person very carefully about their attitude to risk and reward and how they would feel about a positive result. So I see people offering these tests in Singapore online, and I can't imagine a whole lot of pre-test counseling goes on in those situations. I think this is a test. Some people want to do it, and I'm fine with that, and I think it's great, but you've really got to have a careful conversation with a doctor about the pros and cons of doing this and whether it's right for you.
And have the appropriate post-test counseling done as well, which kind of like brings me on to sort of summarizing this in a sense. If you could design the ultimate health screening journey for a patient, and I imagine that's what you've done at Osler, how would you design it? What's the most important part of that process?
So the most important part of the process for me, I think, is that conversation I have with the patient before the tests are ordered. So getting to know them on a person, and I think this is where clearly at Osler, this is where we believe we add value. Otherwise, you could do all this stuff online with a bot, couldn't you? I think the patient comes in the morning fasted, and they have the blood drawn. So it's not like they're hanging around to have the test until they've spoken to me. All the tests are there in the vials, ready to go. But then they have something to eat. They have a coffee, and we have a conversation about what we're going to run, because we can send this blood off for whatever we want. We need to sit down and decide what's right for you. And I think there's often a difference between what I think are the best tests to run and what the patient thinks are the best tests to run. And we got to have a conversation around that and come to a consensus and a shared decision together as to what's the right test for you. I might think that doing a colonoscopy at 45 is the best idea in the world. You might be someone who never wants to go near a colonoscopist in your life. And I've got to then understand that and come up with a plan B or an alternative that works for us both.
That's great. I think that's what I've heard about Osler as well, is that my patients always say that they feel listened to, which is really important. That's what we want, isn't it?
We both think that listening part is the beginning of people getting better as well. So yeah, 100%.
I mean, I think, what we do is quite labor intensive. It costs time and it costs money to sit down with people and have these conversations with them. But what I generally find is the patients that are just going somewhere and choosing off a menu, invariably are spending way more money.
Yeah.
Because they're just so, well, I'll take the platinum package because it seems like the best one. And actually, a lot of what I do when I'm discussing screening tests with people is saying, you don't need that yet. You don't need that now. You never need that one. And so I think that investment of time at the outset can actually pay off down the line, both financially, but also in terms of not exposing you to things that you don't need to do.
Yeah, because that can lead to weeks and months of investigations. That's potentially your whole year ruined of going down rabbit holes for things that you don't have.
Absolutely. And all this just stress around it, of like mental health, like thinking about it, not sleeping because of it.
Yeah.
And what's the highest cause of death for men under 30? It's like mental health issues, isn't it?
Right.
Yeah.
Suicide and accident.
Yeah. So we don't need to be adding to that stress, do we? Dr. Neil, thanks very much. Really enjoyed it again. You are now, I think, can we say he's our official resident GP on the Best of Both Worlds podcast?
Very happy to be.
Definitely.
If you'll have me.
Yeah. Paul.
Thanks a lot for coming, and I hope everyone really enjoyed today's podcast. If you could like, subscribe, and comment. Make sure you're following us on Instagram as well, as we'll be uploading lots of shorts from this video.
And don't forget, your health screening and your health really begins with a conversation and a really good joint decision making. So consider that as you go forward in your health journey.
Thanks a lot.